Hello everyone, welcome to today's session. So this session is specially planned for all of you on demand that everybody wants to know is 2 minutes sufficient to prepare for the MRCG Part 1 July exam or not, right? So bookings were just open 2 days back and most of you have already booked the exam. So now the question comes is what to do in 2 months for those who have already been studying or for those who are now trying to read and who are now starting their preparations. So, is our 2 months sufficient or not? This is another question, right? So, I had already announced the session of data interpretations SBA. So, I thought why not combine these two things so that I can give you the strategy as well, and also we can discuss the data interpretation question. So, I hope you like this idea, and let's proceed with the session today. So first, in few minutes, I'm going to tell you about what strategy to be followed in the next 2 months so that you can drop the exam in one go. And I think we are the right person to talk about it because at MRCOG courses, we have been having a 100% pass rate for almost like 5 years, last 5 years. So I believe you are the next success story of MRCOG courses. So let's rock together and let's talk about the strategy which has been tested over the period and which has always proven and has a track record of bringing in success. So let's start with our tagline, prepare in 70% less study time with us. Yes, when we say 70% less study time, we mean it. And that's why we can tell you that 2 months are more than enough for your part one exam. So let's start. So here we go. So first thing, the question which comes to your mind is, can you clear part one in just 2 months? Yes. If, what are the criteria? If you know, study what matters. It's not about reading all of the books. You know that there are 13 subjects. If you are going to read the book of everything, then of course 2 months is not sufficient. But is that required to pass the exam? That's another important question. So study only what matters. Focus only on the exam tested content, right? It's only the 20% of the syllabus from which your questions come in exam. So focus only on that content. That's very important. And read from the sources the RCOG is looking for so that you answer correctly, right? Many of the questions, they are actually, they are not single correct answer. They are single best answers. What does that mean is you can have more than one answer correct, but the correct answer is best answer is only one. So how to choose the best answer? If you know about the RCOG sources, what is written in the RCOG sources, then you are the one who is going to pick up the single best answer instead of the single correct answer. So if you know that, that's fine. So picking up the right sources is another important thing here. Now, practice question-based learning daily. Yes, that's very, very, very important. And it is not only about practicing the questions, it is about practicing the right type of questions, the high yield questions, so that if you are practicing 20 questions, you know that out of these 20, 12 or 15 are definitely going to come on exam. So if you prepare like this, is it possible to clear your part one in just 2 months? Yes. Time is short, but smart prep is the key. So, if you are ready for the smart prep, then you are ready for the success. So, what actually mistakes most students make? You must have heard about from your friends and everyone. I prepared for part one. I was told that it is very easy. So, I thought I'll just prepare it in 2 months, or I read this only and that only. My seniors told me you just do the recalls and go. Many a times you must have thought about it, right? So, what are the common mistakes? Reading textbooks. People go with the big, big books Not if I don't say textbooks, then also like MRCG Part 1 related books. But again, they are long, takes time, and because you are reading too much content, you may not be able to revise everything. And then once you are not revising, then it is very difficult to remember in the exam and answer the question appropriately. Wasting time on non-exam material. Oh my God, there is so much to study. Now, if you are not focused on the exam material, whatever you are reading is not coming in exam, your effort is getting wasted. Ignoring the RQG recall patterns. So, is this about just doing the recalls and knowing the correct answers? No, because many a times the questions do not come same, but the concepts are repeated. And when I say concepts are repeated, means you need to have all the information about that particular topic. So, what you have to do is from the recalls, pick up a topic, make your own list. From that, take out the content related to it, then revise it, revise it, revise it. So, it's a tedious process. I understand. What is the solution? I'm going to talk about it. Not doing enough practice questions. And the other thing is like you have one book, two book, or maybe you have joined one question bank, so you don't know whether you are doing enough practice or not. So this is how, what are the common mistakes? So you don't need more time, but you need the right plan. So it's not about like 3 months, 4 months, 6 months. It's about the right plan if you have, that should be fast. So now, what is my strategy for 2 months? Fast track strategy. Step one is focus on high yield subjects. Important to focus on the high yield subjects. Devote more time to the subjects from which the questions are going to come. Step two is rely only on the RCOG based sources. So see whatever book, whatever question bank, or whatever course you are taking is teaching you the right content. Practice SBS daily. EMQs are not part of part one exam, but SBS you have to practice daily. Recalls and do the test. Mock. This is very, very, very important because it's like a marathon. You have to build your speed, right? In exam, you have almost 1 minute for one question. So if you are not accustomed to that kind of question answering, it becomes very difficult. So knowing the content is one thing, and then able to fix up that content in that particular time, your mind thinks about it and just ticks it. So what is the good way of doing that? If you are doing it daily on a daily basis, you are already doing it, then your mind takes it as another mock, and then you can just rock the exam as you are rocking your mock. And your anxiety levels are also too low. So doing the recalls, understanding their concepts, going for the high yield topic, and then testing your knowledge simultaneously in the mock. This is the key to success. Review your performance and keep revising your weak areas. So this step-by-step thing is going to help you rock the exam in 2 months. What to study? Targeted content. See what comes in exams and read that only. Past recalls, at least 10 years. That is from the 2015 onwards is the must. RCOG guidelines and whatever the RCOG content, that should be read. And if you don't want to prepare this for everyone, for everything for yourself, then our PDF summaries and video sessions are more about this. And along with the live sessions as well. So finally, all the content at one place on the website. No need to go for any books, books, no question banks, nowhere to go for the mock. Everything is available at one place, and that's the key to success. So our course covers it all topics covered in question format, strategy, RCOG based questions, PDF summaries for all the subjects, summaries, you can just quickly go through it. Do the question wherever you find any issue, you can just check the summary. And then there is a complete support group, Telegram support group, where 24/7 your queries are being answered. Module wise test, and then finally full mock also before you go to the exam. No need to waste your time for making your own plans. We have done this all for you, and we have tested it also for the success multiple times. So now it's only your turn to just walk the same path, enjoy the drive, and get the success. This is how the plan is. So we are starting our crash course from 1st May. You are very much welcome to join. And as soon as you join, you don't have to wait for the first minute, because as soon as you join, your access begins. And as soon as your access begins, you start enjoying the ride. So let's do it together. And this is what our students need to say.
Hello everyone, myself Dr. Harshali Lokhande. I joined MRCUG courses by Dr. Bhawna Khera ma'am in October 2024 for this January Part 1 MRCUG exam. I was in doubt whether we're liable to do it or not with the ongoing job, pregnancy, and hectic schedule. But lastly, I hardly studied for 1 month dedicatedly, and that too only madam's notes, PDF, worksheet, recall session, whatever madam has advised me to do that. I had only done that only and gave the exam and scored 86%. Even I was shocked with my result. I would highly recommend Madam's course to everyone who want to clear Part 1 MRCOG examinations, as Madam says, in less than 70% of the study time. Thank you so much, ma'am.
So you can see this was October admission and January she rocked with 86%, right? So you are at the same shoes right now. You are April and you are looking at the July 2025. So is there any doubt now? No. So you are now, you know
Hello,
what is the path to success. So only thing is that you have to just start walking over it. So if you want to start walking with us, these are the numbers and this is our website. You can be in touch with us. And for our already existing full course students, they have access to the crash course that's included in the course. So we all are going to walk this final step to success from 1st May onwards. And I'll welcome you all into that session. Looking forward to see you all for the next 2 months on your toes with MRCOG courses. Okay, so now let's start our today's session. Meanwhile, if you have any questions, please keep dropping in the YouTube live. I'll be answering all your questions. I'll be happy to give you the clear overview of whatever you are looking for. If you have any questions, you can just start right in the YouTube live down below, and I'll be happy to answer. My number is also here, so if you want to contact me directly, you can do that as well. Now, let's start today's data interpretation session. And please, I will be happy to see you all answering while we are going to discuss the questions in that session. Because finally, it is about your participation which makes it useful. So let's start with the first question. We are going to do 10 questions of data interpretation one after another. And mind you, these are not just the 10 questions, but they will give you more, they will give you the perspective of the more questions which can appear like this in the exam. So let's start. A patient undergoes an oral glucose tolerance test. The results are shown below. Now, what is the fasting plasma glucose level is 5.9 and the 2-hour plasma glucose is 7. So, what does this result show? Yes, I'll wait for your answers and then I'll reply. So, please start answering in the live chat. That's what I'm looking for. Good, very good. I can see the answers there. So, very nice. Okay. So, what is the cutoff? According to NICE diabetes, what is the cutoff for the GDM, right? So if you get confused with the numbers, then it's a very simple way to remember. It is 5678, right? 5.6 is the fasting level and 7.8 is the 2-hour plasma glucose. So 5.6 and 7.8. Easy way to remember is 5678. So now, if you look at the first, that is, it is more than 5.6, so it is 5.9. So therefore, this is the case of, is it the case of gestation diabetes? Yes, 5678, I can see everybody. But what about the correct answer? A, B, C, D. I'm looking for the correct answer. Okay, B, B, B. Is it B? I'm looking for the correct answer. Waiting. E, very good. Very good. That's the correct answer. It is E. This is gestational diabetes because what I said is if any of these one is incorrect, if any of these one is actually the cutoff it is more than the cutoff, then it is gestational diabetes. So if you look at 5, 6, 7, 8, then fasting plasma glucose is 5.9 and the cutoff is 5.6. So this cutoff is broken. The barrier is broken. The patient has got the reading beyond the cutoff. So this is the gestational diabetes. And it is either of one value needs to be abnormal. It's not both the values need to be abnormal, right? So your first cutoff is 5.6. So here it is 5.9. So this one is now GDM. The other one is 7.0 and 7.8 is the cutoff. So the other value is fine. But if any one of these is abnormal, then it is gestational diabetes. So your E option is correct in this, right? So remember it as in a very easy way, 5, 6, 7, 8. Yes, that's the great answer. So E is the correct answer. Fine. So this is from the NICE diabetes in pregnancy. Diagnose the gestational diabetes if the woman has either a fasting plasma glucose level of 5.6 or above, or 2-hour plasma glucose level of 7.8 millimoles per liter or above. Okay. So if you have any doubts, you can also keep on putting that in the live chat as well. I'll be happy to answer. Now coming on to the next question. You review a 61-year-old patient's blood results in pre-op clinic. They are as follows. Now this question is about the calcium metabolism and the calcium hemostasis. That's a very, very, very favorite topic of RCOG, right? This is slightly confusing, but very important. So the corrected calcium is 3. Alkaline phosphatase is 120, which is also in the normal range, but the corrected calcium is slightly towards the higher side. Phosphate 1.5 and the parathyroid hormone is 5, which is normal. So now what is the likely diagnosis in this case? Yes. Looking for the answers, waiting. What is the likely diagnosis in this case? Yes. How do we go about this particular question? Anybody would like to answer this? Or, okay. So, yes, looking for answers, looking for answers. So, yes, let's interpret. Let's see how these findings need to be interpreted, right? This is slightly a tricky question. For now, if I take it, then bone metastasis, hypothyroidism, melanoma, hypoparathyroidism, and vitamin deficiency. Now here only the calcium is increased, right? Only the calcium is slightly increased, rest all are normal. So this is a usual feature of the myeloma. Now let's see how to interpret this chart. So in the first column, if you see ALP is normal, parathyroid is normal, then it is most likely the myeloma. What happens is the bone involvement is there and the patients are usually normocalcemic. That is why I told you there's a very mild rise in the calcium. And the platelet parathyroid hormone is not suppressed too. Now, in the other scenarios where the phosphatase, alkaline phosphatase is normal and parathyroid hormone is low, it is known as the calcium alkali syndrome. And this is due to excessive calcium intake. Now, because the excessive calcium intake has been done, so parathyroid hormone is getting the negative feedback, so it is suppressed. So this is excessive calcium intake leading to calcium alkali syndrome. Now the third is your alkaline phosphatase is either normal or raised and parathyroid hormone is low. So now what is happening here? The alkaline phosphatase which is destroying the bone, that is leading to release of the calcium in the blood and that is leading the parathyroid suppression. So the problem is coming from here, not from the parathyroid gland. So this is now thyrotoxicosis and the sarcoidosis. Then, in this case, where the primary hyperparathyroidism. Now, this is primary. Primary means it starts from the parathyroid gland only, right? So now the parathyroid gland parathormone is rising, and because the parathyroid thyroid hormone is rising, so it is bringing more calcium into the blood. So in this case, you will have the hyperparathyroidism. The next is the malignancy or the bone met. So in this case, again, your this alkaline phosphatase is increased because that is the enzyme which is acting and leading to the resolution of the bone, the dissolution of the bone, and the calcium is coming in the blood, and it is leading to the parathyroid hormone suppression, right? So this is how you can differentiate. So myeloma is almost everything is normal, yet the hypercalcemia is there because that is kind of a paraneoplastic syndrome in these patients. Now we again look at these values to make you more clear. So calcium you think is C is almost normal. Alkaline phosphatase is normal. So that means there is no bone damage there. And phosphate is normal. Parathyroid hormone is also normal, right? So now here it is myeloma, right? Because if it is a hypoparathyroidism, yeah, then your thyroid will be low. Vitamin D deficiency, then alkaline phosphatase will be rising. So here nothing is there. So this is myeloma, right? I hope this is clear. If you have any doubts, you can just let me know and we can go over it again, right? Waiting for your answer. Is it okay? Yes. Okay. Thank you. Thank you so much for letting me know. 45-year-old woman attends the fertility clinic for the results of a recent blood test. Now, in this, the hormone levels are being tested. So, FSH is 54, LH is 30, progesterone is 0.2, prolactin is 20, and PSH is 2.5. What is the most likely cause of her subfertility? Again, so we have to go over the findings. Now, this is the hormonal interpretation. So basically, see, data interpretation is what? You are going to interpret the report. We all interpret the reports in our daily practices. But why it is problematic in the exam? Because every time we do not take the decisions according to the RCG guidelines. But here we have to take the decisions according to the RCOG guidelines. So therefore, it is important that we first learn how to interpret these all tests in relation to our exam scenario. So here it is about what is the most likely cause of fertility. So when FSH is rising, LH is rising. So what is happening here? FSH and LH is rising. So what is happening above 30? It is the menopause. Correct. It is the menopause. Yes. Got the correct answer? Definitely, it's the good thing. So, menopause. Whenever the patient FSH is more than 30, this is consistent with the menopause. Very, very, very important. You in exam you can have two types of questions with this high FSH levels. One is when I talk about like this, I was talking about the diagnosis, right? Now, if this thing happens in a woman who is less than 40 years of the age, then your answer will be premature menopause or the premature ovarian insufficiency. More than 30 in less than 40 years, your answer will be premature ovarian insufficiency. Third thing which comes about this question is like how she can get pregnant, right? What is the way she can get pregnant? So whenever you find the FSH and LH values high, the fertility option for this patient is ovum donation, right? So in this one particular SBA, we have talked about three SBAs, right? One is a woman above 40 years with high FSH and LH. More than 30 is a menopause. Less than 40 is the premature menopause, and the other term is premature ovarian insufficiency. And when we talk about the fertility option for this woman, less than 40 with premature ovarian insufficiency, then the choice is ovum donation. So these are the three questions, and we need to Remember these answers. Yes, correct. Perfect. Yes, over donation. That's absolutely correct. Egg and oocyte donation. Absolutely correct. Thank you being so active in the chat. It's really interesting to see the answers and keep motivated to go about further questions. So let's talk about the fourth question. 32-year-old has a transvaginal ultrasound that shows a left ovarian mass. The ultrasound report describes a unilocular cyst with the acoustic enhancement and diffuse homogeneous ground glass echoes as a result of hemorrhagic debris. What is the likely diagnosis? So there is an ovarian mass and it's a unilocular cyst, but there is diffuse homogeneous ground glass echoes. So what do you suspect in this? And it's an important exam thing, right? You need to know these when you should be clear about the ultrasound pictures, teratoma, endometrioma, the physiological cyst, follicular cyst, then about the ectopic pregnancy, molar pregnancies. These are fibroids. These are important picture questions which appear in the exam, right? So on our website, you will find all the picture questions which are there, and you can easily go over those so that exactly the same picture appears in the exam and you can just blindly tick your answer. So here we go. Yes, I have got the correct answers in the chat. That is the endometrioma. The ground glass homogeneous appearance is the typical of the endometrioma. Very good, everyone. So such a lovely student with such a lovely answers. Endometrioma is defined as a blood-containing pseudocyst resulting from endometriosis, tissue with hemorrhage. Typical ultrasound features of endometrioma are diffuse, homogeneous, low-level echoes. Echoes sometimes described as ground glass, the result of hemorrhagic material. So that's the correct answer. But remember to go through all the important ultrasound images so that you can score well in exam. Lots of picture questions come in exam, so you have to be prepared for those. Okay, coming to the next. 28-year-old is being seen in the early pregnancy unit and you are asked to review her ultrasound. There is no fetal heartbeat. Ultrasound shows a fetal pole. CRL is measured at 7.6 millimeter and what is the likely diagnosis? Now, we have to follow the rules of NICE early pregnancy guideline. So, what is the cutoff for the CRL when we look for the miscarriage? What is the cutoff value for CRL we look at for the diagnosis of miscarriage? Yes, looking forward for your answers. What is the cutoff for CRL when we have to diagnose the miscarriage? Yes, what is the cutoff value? Looking for the cutoff value. No, it's not 8. Yes, very good. That's correct. This is 7. 7 is the cutoff of the CRL when we have to diagnose the miscarriage, right? So if above 7, CRL is above 7 and there is no heartbeat, then this is missed miscarriage, right? So then in that case, this is missed miscarriage, right? If it is below 7 and there is no heartbeat, then we label it as pregnancy of uncertain viability, right? So again, in this same slide, I'm going to talk about 4 questions. One is if the CRL is 7 and above and there is no heartbeat, it is missed miscarriage. If its CRL is less than 7, then it is pregnancy of uncertain viability. Now, if we have a gestational sac diameter here, gestational sac diameter 25 and above, no heartbeat. This is missed miscarriage. Less than 25 mm and no heartbeat is the pregnancy of unknown viability. So remember your cutoff, CRL is 7 and the CRL is 7 and gestational sac is 25. Below this are the pregnancy of uncertain viability. Values above this is the missed miscarriage. So that's how it is. Sorry. Okay. So SBA 6. Oh, Here answer is already showing. I'm quite okay. So quite sorry for that. So you are called to see a 24-year-old patient in accident and emergency. She is 34 weeks gestation and her blood pressure is 147 by 96. Automated testing, reagent strip testing shows protein 2 plus. You send for a protein creatinine ratio and this ratio is 36. What is the appropriate course of action? So, what is the appropriate course of action? Mm. What is the appropriate course of action for this particular patient? So, first thing, what is the diagnosis for this patient? What is the scenario here? What does the scenario reflect? The correct diagnosis. Yes, the answer is correct. A. So, what is the correct diagnosis here? What is the condition? This is This is preeclampsia, right? And for all preeclampsia patients, first thing to do is start the antihypertensive, that is labetalol, and send the blood test. Do we admit all preeclampsia patients? No. We do not admit all preeclampsia patients. We admit only the patients who are severe or who have concerning characteristics, right? So we admit only those. So here it is basically to start the labetalol and send the blood test. That's the correct answer. Very good. Very good. Now coming to the seventh question. Regarding CTG, analysis of variability, which of the following would be classed as non-reassuring according to RCOG guidance? Regarding CTG analysis of variability, which of the following would be classed as non-reassuring according to RCOG guidance? Now what? Analysis of variability, which of the following would be classed as non-reassuring according to RCOG guidance? When do we say the variability is non-reassuring? So what is the normal? What is reassuring? What is non-reassuring? And what is abnormal? That we need to know, right? So yes, this is C. C is the correct answer. Less than 5 beats per minute for 30 to 90 seconds. This is the non-reassuring one. So this is kind of a suspicious, right? If it is crosses more than 50, then it becomes doubtful, right? So basically, this is the C. That's the correct answer. Now, you are asked to review the serology results of 33-year-old woman from China who had deranged liver function test. The results are as follows. HbS-Ag is positive, anti-HbS is negative, anti-HbC is positive, and IgM anti-HbC is negative. Now what? You are asked to review the serology results of 33-year-old woman from China who had deranged liver function test. The results are as follows. Now what to do? Yes, waiting for your answer. So basically, yes, correct. This is a chronic infection. So this is a chronic infection because you see that there is no active thing, right? And antigens are not there. So it is not an active infection, not the IgM antibody is positive. So IgM is negative. That means there is an old infection. But but it is not completely healed. Why it is not completely healed? Because the patient is HbS antigen positive. So HbS antigen is still persisting, but there is no acute thing. So infection is persisting, but there is no acute infection. So therefore, this is chronic infection. Now let's see all the options because I can see some wrong answers in the chat as well. So let's clarify this thing here. So when I say the immune due to past infection, what will happen in the immune due to past infection? Even your HbS antigen is also not positive, because now this is fine, right? Everything is fine. So there is no antigen. The infect antigen positive means still the virus is being carried. So now it is immune, means there is no HBs antigen positive as well. Immune due to vaccination. So in vaccination, only one thing which is used, one antigen which is used for the antibodies is the HBs, right? So HBs antibodies will be there. Only this anti-HBs will be there in the vaccination. Only one thing will be there. Remember as, right? So only one anti-HBs will be there in the vaccination. While in immune due to past infection, your HBs will be negative as well, right? Now coming to acute infection, what will happen? Acute infection will have HBE, right? So that is the one antigen which is definitely present in the acute infection, right? Core antigen will also be, can also be present. So it means the antigens are there and the IgM antibodies are positive in the acute infection. Chronic infection is the one here because the infection is still persisting because HBsAg is positive. But all this is IgG, not IgM, right? So therefore, this is now the chronic infection, right? Everybody okay with this? Any questions? Any questions? You can let me know. Is it clear? Okay, great. So this is chronic infection. Next, coming to the next one. Uh, Next, coming to the fetal blood sample is taken during labor due to failure to progress. What pH is cut off below which delivery should be considered? So, what is the cutoff below which the delivery should be considered? So, remember, the problem is when the pH falls below 7.25. Now, but 7.25 is not the cutoff, right? So it is important to remember your monitoring starts when it is below 7.25. So between the 7.20 and 7.25, it is suspicious, right? So we do not act. It is suspicious. When we go below 7.25, then it is abnormal. And in this case, we have to act. Below 7.20, sorry. Then we act. So the correct answer here is the B. That is below 7.20, we have to act. Below 7.25 is suspicious and below 7.20 is completely abnormal and you need to act there. So 7.20 is the correct answer. Okay, great. Okay, so this is the last question for today. 34-year-old woman has just returned to the UK following the missionary work in the northern parts of South America. She is delighted to be pregnant and presents for booking at 12 weeks of gestation. After counseling, she agrees to have routine blood investigations, including screening for syphilis. The results are returned as follows. VDRL reactive, Treponema pallidum particle agglutination test non-reactive, and FTABS non-reacting. Reactive. What is the most likely appropriate interpretation of these results? Now your VDRL is positive, but the TPPA and the FTABS is non-reactive. So now what should be the correct answer here? Yes, absolutely correct. This is the D, right? So what is happening here is that ideally we diagnose syphilis if the treponema specific tests are positive. So your FTABS and the TPPA, they are the treponema specific tests. So to diagnose the syphilis, these tests should be positive twice, right? Twice they should be positive, but they are negative. VDRL is predominant to look for the level of the antibodies, right? That will give us the quantification, how much the infection is. And when we start the treatment, we can monitor the VDRL values to see how the effect is coming for the treatment, that it should fall. And finally, it should vanish. So therefore, now in this case, the treponemal specific tests are not positive, but the non-treponemal specific test is positive. So what is there? This is biological false positive test, right? So this is false positive biological. So this is not uncommon in the pregnancy. Pregnancy, rheumatoid arthritis, these are some of the conditions where you can find the biological false positive test. And this is one of the favorite questions of RCOG. Out of these 10 questions, you can at least think about 2 to 3 questions coming in your exam, right? So I hope you all enjoyed the session today. Would be happy to know how did you find the session? What next topic would you like to know? And we can discuss in the next session. You can let me know, and I'll certainly plan it soon. So you don't have to be great to start. So don't bring a self doubt whether I can do or not. But you have to start to be a great. So let's do this. Start now. And if you haven't started with us till now, then this is the number and this is the website where you can just go ahead and the success in just 2 months will be yours. Thank you so much for joining today. And just let me know what next topic you want, and I'll certainly be happy to take over. Thank you so much for joining, and thank you so much for being here active in the live chat. Thank you.